Thank you very much, sir, ladies and gentlemen. This is a first topic on cardiac arrest on ECMO, the extracorporeal membrane oxygenation, or ECLS, extracorporeal life support. The two are pretty much interchangeable. It's always the same thing. It is some type of arterial venous extracorporeal circulation, so it is external. Now, this type of care was something that has been introduced several years ago in treatment for cardiac arrests, and there are some results that are relatively positive in some cases. You've probably heard of these. You know, for example, that when the cardiac arrest is due to poisoning, it works. If it's a question of intoxication or poisoning, then it works. This patient recovered, and in this first study that was done by Bruno Mederven at La Riboisière, it was extremely positive. When you look at the overall results of ECMO on cardiac arrest that occurs in the hospital, that is an intra-hospital cardiac arrest, then you can see, and it's quite clear on these survival curves, that you have an improvement of survival because of the use of this technique for patients that have suffered a cardiac arrest and whose heart is not starting up again, so they do not recover spontaneous circulation. So up to now, everything appears simple, but most of these cardiac arrests do not occur in the hospital. They occur outside of the hospital. And you know that these are the sudden deaths. We've discussed a lot of these in this Congress. And in this case, it's the ambulance, the SAMU, who comes. People ring the 15. Our people go in with the emergency medical team. The first treatment is given, and there are two types of solutions. First of all, the patient will recover cardiac activity, and then they rush to the hospital. Normally, they go to a unit, to a ward or a hospital that is used to dealing with these patients, those who are suffering from cardiac arrest, or their hearts do not start up again. So what do we do then? And normally, after a certain number of time, we stop everything. After 30 minutes of life support attempts, we stop everything. But things have changed now because when we need a doctor to intervene, but there are other possibilities. Either you continue to resuscitate, you analyze the circumstances of the cardiac arrest, you can try to extend the resuscitation technique by using these ECMO techniques. Today I'm not going to talk about actually taking a patient to a place where you isolate the kidney circulation, where you do certain complex things, but that is a treatment that can be used. It's a societal one, it's a collective one, but we'll talk about circulatory assistance. We did an expert meeting not so long ago in 2009, and this expert meeting decided that hypothermia or that intoxication were good indications for this. Now, this is interesting because it is something that is still topical today, and also a certain number of CO2 or the biology. And it was decided that when you had these indications, you were allowed to suggest a transport with a mechanical cardiac massage into a hospital that can immediately set up some type of circulatory assistance. And the patient survives maybe, but their brain does not, cerebral death. Or suddenly you have an uncontrollable hemorrhage. Now, the first article that appeared in 2011 from the Salpêtrière showed that these out-of-hospital refractory cardiac arrests, the results were catastrophic. Cardiac arrests that were resuscitated in the hospital with circulatory assistance when the cardiac arrest was a pre-hospital one are almost doomed. There is hardly any survival out of the 50 patients. There were only 2 who survived. And we don't quite know why. Whereas we saw that in hospital cardiac arrest, the results were not at all the same, because there you can react on the extent of time, the length of time before you actually set up the circulatory assistance. And Shane, in an article, a recent article, shows very clearly that when you have been treating for 30 minutes minus 60 minutes, you can see a great delta between circulatory assistance and the lack of this assistance for a cardiac arrest that is refractory. So this author, Kagawa, Japanese, Japan being one of the countries that uses ECMO very frequently, did the following piece of work. He eliminated the origins of the cardiac arrest and he compared the time factor. And when you compare the in-hospital cardiac arrest to the out-of-hospital cardiac arrest, in this case, if you adjust this to time, there is no difference in survival between the two. It's not the cause of the cardiac arrest or where it occurs, it is quite obviously the way in which it is treated. And this has been confirmed recently by other authors. Sakamoto shows that the prognostic between patients who benefit from an ECSA and those who do not is in favor of those who benefit from this assistance. But in the same database, Wong shows that the time factor is very important. If you can set up your assistance, your ECMO very quickly, you have good results. But unfortunately, even in the systems that go extremely quickly, and that's the case of the Japanese, they take the Japanese, they do what we call a scoop and run. They massage and they whisk them off to ICU. But even in minimizing transport time, it is not sufficient. So we have to think about things differently. And that is why I think that we could perhaps an indication for ECLS would be to transport them in the SMUR, do the cardiac massage, and then take them straight away to ICU. Now, I see people here standing up who are saying it's not going to work, it's complicated, the technique is too difficult, you're going to lose time, waste time, you don't have a system that enables you to do this. Is it feasible to do the ECLS in a pre-hospital setting? Yes, we do it all the time. You just need the human factor, you need a team, you need doctors, you need to be able to get the circulation moving again, you have to have the logistics, you have to have the necessary equipment with you, it has to be portable, and over time all of this has improved, which means that we've been able to train doctors with surgical teams who are very cognizant with the technique so that in a simulatory exercise they can actually set up a pre-hospital ECLS while others were only setting it up in the ICU. And in several years this is now being used by people who are not necessarily cardiac surgeons. This technique has been modified. We have a technique, an implantation technique. First of all, there is a primary incision. You can stabilize your cannula very rapidly, and as you can see in this photo, it means that you can also set up an anterograde reperfusion because the underlying member is something that we can work on far more quickly than we thought. You also have to deal with the cardiac arrest itself, not just the ECMO. You do a blood transfusion and plasma as well. You apply dobutamine or norepinephrine infusion, volume loading. You can also do treatment for hypothermia induced by infusion of fresh saline serum and by priming the ECLS with fresh saline serum. And in the cath lab, you can either do a direct admission for coronary angiography or for patients with clinical electrical signs of AMI. And these are most of the cases that we see presenting in hospitals with cardiac arrests. What about safety and feasibility? The first series that we studied on just a few patients showed that it is possible to do this. It is possible to do it quickly in 22 minutes. It is possible to have a relatively short time between the moment when you take the patient and the moment when the ECLS is set up. There can be one or two problems, movements or fixations that are not stable. The cannula sometimes move, but we don't necessarily have infectious complications. And the length of the use of the ECMO is shorter. The length of stay in the ICU is between 6 and 7.5 days. Several patients died, but several also survived. You can see the time of setting up the equipment. In this case, it was a Japanese 32-year-old tourist who was in France, and the Japanese found it absolutely normal that an ECMO was used because they do it all the time. Now, let's get back to the time factor. If you compare the time it takes, comparison of pre-hospital VS in hospital ECLS strategy, you can see in this series, and in another series I'll show you in just a minute, there is quite clearly several, you can save several dozens of minutes between the pre-hospital ECLS strategy and the in-hospital one. again, quite clearly, the decrease in time by setting all of this up in a pre-hospital setting does not give rise to any waste of time, because in the field you can set up the ECMO by teams who have been trained to do it. And whether you do it outside of hospital or in the hospital, it takes more or less the same time. So the benefit is quite considerable. Here, this is ECMO in the Louvre, in front of in the pyramid of the Louvre, and the extracorporeal life support system is being set up. There you've got it in the street, you've got it in a supermarket, you've got it in the metro. So again, you can see that the SAMU, the people are saying, well, the SAMU is doing things that are not very necessary, but that's not the point. The point is to know how can you rapidly treat these patients. If we're going to continue to work afterwards, it doesn't mean that we have to do everything in a pre-hospital setting. That's a bad idea. We have to do things quickly, but we have to do them well. So the idea is the complementarity between pre-hospital treatment and in-hospital treatment. And what we've done since then is that we have tried to think on a case-by-case basis as to the strategy that is going to be the most beneficial for the treatment, the most beneficial for the patient, which means that we have to know exactly what we're going to do. We have to analyze the cases on a case-by-case basis. We have to decide as to when the ECLS will be best, either in a pre-hospital setting or in a hospital setting. And then we did a little experiment on some 100 patients, and we mixed up the results, and you can see the results here. About 10% of patients survive if you set up the life support system very rapidly. 10% of patients that before would have been left, would have died in the field, who have actually survived. If you look at a general series of cardiac arrest, 10% survival is not a bad outcome. The second thing is that when you actually treat cardiac arrest, you are working against time. Time is against you. You have to know whether you can repair the heart and whether the brain is going to survive. And you have only a few minutes to decide whether you're going to stop resuscitation or not. It's difficult. The life support system will give you a little bit of time to be able to englobe those parameters and to look at these parameters in a much more serene manner. You have time. Something is replacing the brain. Will the brain recover or not? To what extent has the brain been damaged? What are the cerebral lesions? You have more time to look at this. And the second thing is that if you know what the cerebral prognostic is going to be relatively quickly, that's going to have an impact on a certain number of patients. There are some patients that you cannot save, but they can become organ donors, and that amounts to about 10% of the patients. There will be 10% who are going to die, but who will be able to become organ donors, whereas they would never have been able to be organ donors without the life support system. So there are some patients where there is a future, not necessarily for them, but as organ donors. Now, there are still a lot of significant questions that we still have to look at. What is a refractory cardiac arrest? Moyati just 2 years ago tried to define this, and the Dr. Gercourt tried to define it as well. If we look at literature, at 16 minutes, there is only 1% survival rate. Should we do as the Japanese do, or the Koreans, who very quickly set up ECLS for cardiac arrest? Second question, do we have the right indications? No, we don't. But there are some that are appearing today. There is a big French register that is listing all of the cardiac arrests. And there are some positive things there. If there are signs of life during the cardiac massage, that's a good factor. If you have a ventricular tachycardy, that is a good sign as well. If you have a return to cardiac rhythm in a pre-hospital setting, that is a good indication. Signs of life in the hospital, that is a good sign of indication as well. Asystole is 100% of death. So very the third question we have to ask ourselves is, are we going to do this? Are we going to set up a life support system every 20 kilometers? The post-hospital, pre-hospital ECLS can also be done in a helicopter. Helicopters can be adapted for this, so it would be possible to cover the whole of the territory. And here you would have, if you have an AC with a no flow, 0 minutes alert, they can take off with the helicopter can take off within 18 minutes. It takes 50 minutes to set up the equipment, and there would be survival. So the conclusion is the hospital. A pre-hospital ECLS for refractory cardiac arrest is not a myth. myth. It is an option. It is an option in a strategy of rapid access to these cardiac arrests. Its indications and its place and its development are being assessed at the moment, and there will be, in the beginning of this year, the first semester of this year, there will be a European multicentric study that is going to be carried out, which I hope will apply